right, welcome everybody. Hopefully this is coming through okay. All right. Welcome to this panel on data science and surveillance and emerging infectious disease threats. I'm Laura White. We're pleased to welcome you here today. I'll be moderating this session with Dr. Kayoko Shioda. We co-direct a core in the Center for Emerging Infectious Diseases on data science and surveillance. So we're really pleased to have an event here today with a distinguished panel to really start discussing and thinking a bit about how data science and emerging technologies can play a role in understanding and tracking emerging infectious disease threats. Just a word about the Center on Emerging Infectious Diseases here at Boston University. This is a center that really aims to bring together experts, focuses in a wide variety of areas from basic science to communications, epidemiology modeling, and kind of everything in between. So we focus a lot in our particular core on data science and surveillance and think a lot about data and technologies involved with that. And we're hoping to have some discussions about that today. So today's events will really focus on important topics in today's data-rich world. We want to discuss with members of our distinguished panel the ways in which we can use data and technologies better to more rapidly understand emerging infectious disease threats and have better surveillance systems to track them. Kayoko is going to now give some brief introductions for our panelists, and then we will give them each an opportunity to introduce themselves, a little bit of their experience in this area. They come from very different types of areas of expertise. And then we have some prepared questions we'll go through and plan to leave time also for Q&A from the audience, both in person and online. So if you're online, please feel free to put your questions in the chat or Q&A. We'll keep an eye on those. And in person, we'll make sure we make some time for questions as well. So turn it over to Kayoko.
Yeah. Well, thank you so much. We're very excited to have a wonderful group of panelists here today, and I will introduce each of them. So Dr. Mary Madoff is an infectious disease physician specializing in the epidemiology of emerging pathogens, bacterial pathogenesis, and international health. And he is serving as a medical director of the Bureau of Infectious Disease and Laboratory Science for Massachusetts DPH. And he's also a professor of medicine at UMass. And he directed the program for monitoring emerging diseases, ProMed, from 2002 to 2021. And he's now editor emeritus. And Dr. Alex Vespignani is the director of the Network Science Institute and Sternberg Family Distinguished University Professor with interdisciplinary appointments in various colleges at Northeastern University. And he has worked in various areas of statistical physics and computational sciences, but recently he has been focusing his research activity in modeling the spatial spread of epidemics, including the realistic and data-driven computational modeling of EIDs. And Dr. Vespignani is the principal investigator of the CDC-funded Epistorm Consortium, which aims to develop better data analytic tools to be prepared for the future EID threats, which Laura and I have been part of. And Dr. Caroline Buckee is a professor of epidemiology at Harvard T.H. Chan School of Public Health, and she's also an associate director of Harvard CCDD, Center for Communicable Disease Dynamics. And her work is focused on understanding the mechanisms driving the spread of infectious diseases that impact the most vulnerable populations worldwide, particularly malaria. Dr. Buckee's group uses a range of mathematical models, experimental and genomic data, and big data from mobile phones and satellites to understand how human pathogens spread and may be controlled. So maybe we can start with a brief introduction of each.
Yeah, sure. Is this on? Okay. Hi, everyone. Thank you for having me. So I... It is for the online people. Can they hear? Yes, it looks like they can. Okay. So I have, for most of my career, I've worked on vector-borne infections, mostly malaria, some dengue, and I've dabbled in cholera and some other things. And most of the work that I've done has been in the global south because malaria is a disease of the tropics and subtropics, but also because I think that we need to be applying new approaches specifically to target the most vulnerable populations globally. So what we've been focused on in my group is how we integrate new sources of data to help control programs, mostly at the national level, to make better resource allocation decisions. In the context of vector-borne diseases, that's important because you have a range of different interventions. There's not a vaccine, so you have bed nets, you have spraying, you have to make sure there's treatments.
Okay. So, so we help national control programs do a better job. One of the things that's really changed over the last 20 years is that traditional sources of epidemiological data that you would get from routine surveillance systems is now no longer the only source of data that you can use to actually make some of these decisions. And so we've worked on incorporating things like mobile phone data to understand how people are moving around, genomic data from pathogens to understand how different populations are connected to each other, satellite information about how patterns of deforestation are impacting transmission, and all of these kinds of things. And I think for me, the big question is, where do you put your analytic capacity? How do you actually integrate these new sources in health systems, especially fragile health systems in low-income settings, where we don't necessarily have the technical capacity and the resources to throw money and computation at the problem? So I'll stop there, but that's what we are focused on.
Hi, thank you as well. It's an honor to be here. And yeah, my background is as a physicist and then computational scientist. So my entry point was a bit different. It was about 20 years ago. And just by chance, I asked myself, if we would have the airline data, we could probably monitor what's happened to the spread of infectious diseases. There were some, how to say, pioneer papers and publication by, how to say, Ira Longini, other major, how to say, epidemiology person experts. But, you know, they were always done with small data. And at that time, I thought that the state of the art was different in a sense. Instead, you know, when I went to the International Aviation Association and I asked for the data, they sent me back an Excel file. And that for me was a kind of, what? Still an Excel file? What is that? You know, it's really, you are, you know, you have all the, and it took 20 years to change completely. But from there, I entered into this idea of integrating in models, you know, novel data sources that finally are digitally available in a different way than an Excel file, mobile phone data, and many other data sources that have become available with all the limitations that we have in those data sources, and probably we will discuss later. Then my work has been focusing a lot in responding to major emergency health threats. So I did start to collaborate with agencies during the H1N1 pandemic. Then there was several outbreaks of Ebola, and then Zika. That was my experience in mosquito-borne diseases. And then COVID. Now, a large part of my interest is really to bring the state of the art of forecasting and analytics tool to a different level, where we don't have to go to single individual teams asking, what do you think it will happen tomorrow, but to have something that is really a more standard and consensus view of the field. And I think this is one of the aim of the center. We are all in also with Kayoko and Laura in the sense of creating a community around the construction of really a national service for forecasting and outbreak analytics. Thank you.
Thanks. Trying to think of where to start here. So I'm the outlier in that I'm not a data scientist, and I guess where I sit in the Department of Public Health, first I'm a physician, and we are both a user of the products that Alex and Carolyn produce, the forecasts, the analytics that they produce and discover, and also a source of data for many. And sitting in the state health department, we have privileged access, I guess, to a wealth of data that other people often want. And so we've been able to, I guess, exploit that connection to be able to develop some really interesting collaborations, to be able to help others produce, I think, important and worthwhile work, and then to benefit from those kinds of work, that analysis. I was gonna spend a minute or two just talking about the kinds of data that we are privy to. One of the, sort of our bread and butter of data are lab reports, actually. And so we get millions of lab reports of infectious diseases that are reported to us electronically daily. Honestly, we've, just an ocean of lab reports that come in on each of the 100 or so reportable infectious diseases in the state. And those all flow into an epidemiologic system that allows our epidemiologists to actually look at case by case, flow into workflows that our epidemiologists then explore and see what happened here. What is this really? What is this flu diagnostic? What is this blood culture isolate of strep pneumonia? What does it mean? Who is this person? How do we collect the data? And they aggregate and manage the cases, actually, deal with the individuals and do shoe leather epidemiology on these cases. We also, one of the information systems that we were talking about earlier that I was discussing with Kayoko and Laura is our immunization registry. So we have the closest thing to a population-based database in the state. Really, every man, woman, and child is in this system. There are millions and millions of records of every person who gets every vaccine in the state. It's mandated by law. Every vaccination is reported to us, and again, aggregated, and we have access to those data. And they are used for a whole variety of purposes, these data, including, we have a collaboration with the Vaccine Safety Data Link project that looks for adverse events following vaccination, trying to look for health events that follow within a defined period of time after vaccination. And the MIIS provides the data for that. We have case records. We have we have the hospital, we used to call the hospital discharge database, now the case mix database, that has data on every single hospitalization in the state, all of our acute care hospitals, everyone who's admitted, their diagnoses, their diagnostic codes, their length of hospitalization, their lab tests, their x-rays, their costs, their everything that happened to them during that hospitalization is another really rich source of data that we've used. We have a syndromic system that monitors all of the emergency departments and most of the urgent care centers in the state. So we see on a really near real-time basis, every time someone walks into an emergency room and their chief complaint contains cough or fever or urinary tract infection. These complaints are recorded and reported to us in almost real time, so that we can keep track of a syndrome. We know when the flu season is coming. We know when there's a norovirus outbreak at a school, because we see that spike in those diagnoses. And again, that's an incredibly rich source of data. These are just a handful of examples of the kinds of data that we see. I also wanted to, Kayoko mentioned that I worked as the editor of ProMed, which was the Program for Monitoring Emerging Diseases, which uses an entirely different sort of data for looking at infectious disease and infectious disease outbreaks. It looks at unofficial, unstructured sources of data, personal reports, media reports, for example, and reports on those and uses those as the data source for reporting and monitoring emerging infectious diseases. So it's a whole different set of kinds of data that we're looking at. And I will just mention that, we are increasingly aware of all of the other kinds of data that can inform health and public health, vital records, pharmacy data, just mobility, just to name some of the kinds of, where people are using their cell phone and how far they move with their cell phone, are all different kinds of data. We're increasingly using wastewater as a source of information. And I've recently become involved in a new effort around pathogen genomics, which I honestly think is going to be a large contributor to the future of public health, understanding the genomes of the pathogens that we see, and yet a whole other rich and vast source of data that we need to be able to manage and understand.
Thank you. Great introductions. Nice to have such variety of perspectives here. So first question we wanted to start off with, whoever wants to answer, it could be all of you, or if you want to defer, that's also fine. Lancet has just commissioned a report to solicit experiences people have had seeing data science and work effectively in creating evidence that's been translated into policy. We were curious if you have any thoughts on that, if you've had specific experiences where you've sort of seen that work. I think sometimes those worlds can seem to operate quite independently of each other. And we're hoping to see if there have been some success stories or even how you might see that changing in the future.
So the example, I would say I've been working for a long time on use of mobile phone data to improve models. I honestly think I'm not sure that we have massive success in that area yet. I think it's very useful for some things, intercity movements, and so on. But like the contact tracing fiasco during the pandemic wasn't good. And, so I think there's still a lot of methodological work needs to be done to understand biases in those kinds of data. I think the pathogen genomics thing is very important. And one concrete example is the use of parasite genomics to understand how malaria parasites are moving between different places, and in a very concrete way to inform elimination status for countries that are looking to get WHO certified for elimination. So in order to be technically eliminated, and on the list of countries that have eliminated, you have to be able to show no local transmission for 3 years in a row, but you can have imported cases. So the question is, how do you prove that something is an imported case? And traditionally it would be travel histories. We know that travel histories are sometimes uncertain. And so there has been a systematic effort to understand the genomic signatures so that we can start to understand patterns of migration and link that to some very concrete goals for countries. Similarly, looking at therapeutic efficacy studies for malaria. So monitoring drug resistance, monitoring insecticide resistance, where we know the genetic basis of whether a drug is working or not. In the context of artemisinin, for example, we know the gene that is going to encode resistance to our frontline treatment for severe malaria. And genomics has now become a standard way for a country to look for and make sure that they're doing okay with respect to drug resistance. So I think the pathogen genomics, although during COVID, a lot of countries invested in genomic technologies and were assisted in buying sequencing machines and things like that. I think there's an open question of how to keep those going, how to keep the demand for that going in peacetime, as it were, rather than during a pandemic. And I think a lot of countries are struggling with that. Like, are we doing routine monitoring? Do we have enough stuff to do routine monitoring to keep the capacity in place? But I do think that it's going to become a routine source of data from all kinds of public health uses.
Well, I agree with Caroline that successes, clear successes, it's difficult to find and pinch. I think there is a lot of the unsuccess is also due to the difficulty in communications and not because there was no success. I think in terms of, how to say, if we go back to the early days of the pandemic, in a way, the analytical tools, the models, whatever, they were sounding an alarm. They were telling important things. In many cases, they were not, just heard, like the classic example, we just closed the traveling pattern to China and then we are safe, and then things like that. I think so in a sense, I think there is more success than what it seems. At the same time, I think we have to improve in the success of communication and the way we communicate. I have to be honest, in the trajectory that I've seen along many years, for instance, in this business of traveling, this is something I've been particularly active in international things. For instance, at last, with the Omicron example, we were able, to work out, if you remember, everybody wanted to close the traveling to South Africa. There was this major, do a travel ban. Obviously, was completely useless at that point. We had hundreds of cases already dispersed, etc. And together with other colleagues at the CDC and other modeling groups, we were able to produce evidence that actually the closing travels and imposing bans was really not having an effect on the trajectory of the epidemic locally. And at that point, I think this has been, I would say, reverse the policies that were. So this is I think is where we should go, in to have this kind of regular communications in which also the policymakers understand at this point the models and what they are telling, the analytical tools, because initially there is also that, you get there with I always say is for a policymakers, there is a major difference. In many cases, the weather forecast is used as a kind of metaphor, no? But, when you have a weather forecast and you project the path of a hurricane, you don't just have the numerics and the modeling tools, because it's a modeling, it's a model, that trajectory. But also you have a nice photo from a satellite of the big storm. And then everybody believes that, and everybody understands what you're talking in terms also in terms of uncertainty, et cetera, et cetera. I think in our field there was much less that kind of communication and use and exercise. I think during the pandemic a lot happened, and so there has been successes, and I'm hopeful that there will be more successes.
That's a kind of a tough question, where there's a lot of failures or not so successful ventures. We use a lot of our data sources to provide what it's situational awareness, right? I mean, where are we headed? What are the problems? What do we need to focus on? And so, that's, in a sense, that's a success. You can't always measure that, but that's honestly how a lot of data are used. Our syndromic surveillance, where are we in the flu season? What's the status of drug resistance in TB? How many syphilis cases are we seeing in babies? Things like that are situational awareness, help keep us informed, let us inform the public what's going on now, and what should you be doing? What should you be acting on? It's hard to look at race ethnicity data and look to many successes, but I'll try to find one in there. So I think early in the pandemic, in the COVID pandemic, we recognized that some communities were more affected than others by COVID, that it really hit hard in certain racial and ethnic minorities. And, I think those kinds of data were available to us, and we recognized that problem early in the pandemic. And promoting racial and ethnic equity is a key, if not the key, mission of public health. So I think we did focus on that. We developed a program to intensify vaccination in the communities that were most affected. That was called our Vaccine Equity Initiative. And, we put clinics in Chelsea and in Roxbury and in parts of Western Massachusetts that were being hit hard by the pandemic, and we were able to improve vaccination rates, get them at least, and what we measured, it was compared to, the rest of the state. How were these communities doing? What was going on in those communities? So I think that was at least a partial success story. Not that we have achieved racial equity in health care delivery, but we moved at least a bit in that direction.
Thank you so much. So we talked about the importance of communication between the researchers and the governments and the other partners, and also the DPH being the producer and also consumer of these data. So these things highlight the importance of cross-institution collaboration. And do you see what are the difficulties, challenges that make it difficult to do cross-institution collaboration, and what are the barriers, and what do you think would be potential solution to these issues?
So there's a fundamental problem here where academia is slow and general. So we produce models and things that we hope are generalizable, and it takes time, and and public health practitioners have to make decisions that are urgent and specific, right? If you or I write a paper that says this is a model of Chelsea, it won't get published in Science or Nature because it's too specific and it's not generalizable. So we are incentivized as academics to do like high level general types of things, and the timescales are slow when it comes to public health. So I think that there's a fundamental tension here between academia and public health. I do think that there are ways that we can bridge that gap. And we need general models. I'm not saying that. But I do think that what that tension has done is it has encouraged, for example, the proliferation of dashboards that were just sort of handed down to public health practitioners as if they were the truth, right? And because in many public health departments, and I'm speaking mostly globally, not necessarily here, but because they don't have the technical capacity and background in modeling, they were unable to evaluate the uncertainty. And back to what Alex was saying about communication, with insufficient communication and an overly general model that is great for publication, but it's not specific and it doesn't involve the local contextual knowledge that's going to be essential for the decisions people are trying to make. So there's often this mismatch. So it's very clever paper in science or whatever, but it's not useful for the person who has to make a decision about who needs to be vaccinated. And I think this is one of the most important challenges coming out of the pandemic. What institutional structures can we develop to try to make academic outputs more useful and to make sure that there's this iterative loop to communicate those needs? And I think the CFA is an attempt to do this, a very explicit attempt, as well as the centers, right? So we were just talking before the panel that it's not necessarily like a research center in the sense that you're doing big picture thinking. You have very specific deliverables because exactly for the reasons that I just mentioned. So despite this intrinsic tension, I think we are understanding more what it does. In the context of low-income countries and with fragile health systems, for me, the most important thing is long-term engagement and trust. So you need to build up trusted partnerships where both parties are respected for the knowledge that they bring to the table when you're trying to solve a problem. And unfortunately, the funding structure for academia does not incentivize long-term partnerships and applied research. So I think that's something where we need to shift how we think about academic funding and incentives for applied public health research.
Yeah, you said everything in a sense for the academic part. No, it's I really, for me, generally what I say is that we have to overcome the academic model in terms of doing research in public health. So the academic model has incentives and rewards which are not right for public health. So, and the rewards are the elite publications, the fact that you produce something, and it's not just the fact that you do a general model, it's also that then you move on. You forget completely about it. You don't, there is no reliability, there is no dependability on what you do. It's out there. Okay, who cares? I don't have to transfer to the real world or whatever. There is a lot of competition. You were talking about collaborations, and actually, instead, most often than not, the teams are competing. So there is an issue with data. I know a lot of teams which are sitting on their data just because they want to make, their one or two glamorous publications, and then, perhaps we will share with the community, perhaps, in many cases, no. So we have to go completely into different models in which we reward the collaboration. We reward the fact that you don't do perhaps a publication, but you have instead something that is handed to Larry, and he can use it for real. And how in academia you reward that is a question mark. There is also one more thing that I think is related to successes. During the pandemic, everybody turned to academia to say, okay, what's going on? How you can help? But in many cases, we were not, we are not, like prepared for that. We don't have teams that can, that are in standby to become operational, things like that. So really, we need to change this and create a structure where academia support the operational branch of agencies and health department in a way, but with clear incentives that are for the community, to benefit the community. And to do that, really, we need to change a lot. I think CFA and this initiative is called Insight from the Center for Disease Control through the Center of Forecasting and Outbreak Analytics is helping in that sense, is creating a community around those shared goals. I think is not enough. We need to do more, and we need to have a larger community. I know that is, it's unpopular, but we have also to say, I think that the public health funding is very little compared to many, many other activities. And, if you compare with what is the things like the National Weather Service and other agencies and other things, we can do much, much better in this area. Then I'm not talking about medical research, that is a different field. But public health, I think we are at a turning point in which we can reinvent public health, especially in its relation with academia, and make things much, much better for who is the end user and the stakeholders in the field.
Thanks, Alex. So I'm speaking about barriers. I mean, I think you guys have talked about some of the big picture, differences in mission and differences in incentives between academia and maybe official public health. But I was just going to talk about some of the small barriers to using data that are often just seem trivial, but stop you from doing anything. Technical barriers, for example. I'm just thinking of an example where we were trying to import race ethnicity data from an electronic health record system, from Epic, into our system, and we couldn't be into the HAI system, the hospital acquired infections system that the department uses and CDC uses, and we couldn't because the categorizations were different. So in other words, there was not a one-to-one correspondence between the categories that we use to classify race ethnicity and the categories that Epic used. And so it was a technical barrier, essentially. Somebody could have written a routine that would translate or go back and forth between these systems, but it didn't exist. It cost money. It would take time. And so we don't have access to those data. And there are so many other barriers that can be legal, they can be, regulatory, they can be commercial, that companies don't want to share their information. Insurers have vast databases that they won't necessarily share. The payer claims database that I was talking about on hospitalizations is a really wealthy set of data around hospitalizations, but it's not available for a year after the data are input because of regulatory and anti-competitive concerns and so forth. And so we don't have access to those data sort of until it's too late. Anyway, so I just wanted to mention those kinds of barriers too.
Thank you. I think this next question, I think we've alluded to this. It's because I think it's a big, gnarly monster that we've dealt with over and over, and I think had to come to grips with and face a bit is the challenges I think we've experienced and that really were highlighted in the COVID-19 pandemic around equity, that certain communities did all right, and other communities it was absolutely devastating, both in this country and globally. I think, we would like to hope data science might be able to help out a bit with this in the future. And I'm curious what you think opportunities are there. Is there hope that this could somehow not be quite as bad next time around? Or what are the low-hanging fruit or the things that we could do that are better? I think Larry's brought up, clearly there's a lot of issues around data that are, we have a hand tied behind our back already. But what could other things be that might be able to help us sort of tackle this?
I don't want to go first because I'm very pessimistic about this. So I'll let somebody more hopeful talk, and then maybe I'll say something.
And then I pass to Larry. I want to be optimistic, although for instance, in terms of analytics, tools, models, I think there is very little about communities, and that's for sure because of lack of data. Also, lack of incentive. Again, in some cases, it's better to have the grand view than, focusing on a local problem. There is another issue when you work with this specific strata of the population. You really have to get a commitment to that problem, to the knowledge of that problem. You have to embed in the problem, in the community. You have to be there, in many cases. And this is not happening often in the data science and tech world, where there is more the attitude to say, well, technology is the solution, while in many cases it's not just that. And so, yes, there are a lot of barriers. Again, my optimism comes from, for instance, with our center, but many other centers of this initiative, there is a lot of focus on specific small communities, small populations, try to get the right data to address specific inequity and inequality issues. It's tough. It's a tough job. And then when we go to low and middle income countries, the things acquires an order of magnitude more of problems. And also at that point, who is the stakeholders that really can favor, the solution and provide the resources to start working on the problem. So.
I can. Yeah. If you work on malaria, you already know that for most countries, nobody cares about poor people because nobody needs to die of malaria, and they do. And it's always basically rural, poor populations. And so COVID-19 just confirmed this in every country, including this one, with the racial equity very focused here in this country, especially. One of the things that we're doing that I think is actually hopeful, and this is not in relation to infectious disease, but rather heat adaptation and climate change in India, is starting to think about how community-based organizations can be empowered to use their own data for advocacy, collect their own data, conduct simple research, which they can use to leverage policy changes to try and get, for example, into different health insurance schemes or, policies for farmers or whatever else. I do think that what we have to take this idea that you do clever analytics on a giant computer somewhere in the global north and then you export product somewhere. We have to turn that on its head, and we have to say, how can we use things like AI and smart data platforms at the community level instead of up here on simple computers, on laptops, like one laptop, one phone, offline, off-grid, to start doing research at a much lower level that can feed into programs. Because when you go and you actually work with communities, I work in Guyana, and when we go and we talk to the communities, they know exactly what's going on. They know what species of malaria they've had. They know why. They know who's bringing it. They know what's happening. And so for me, it's really about trying to get the whole notion of data science and computation down at that lower community level so that we can start using that data more sensibly and informing policy from the bottom up rather than always thinking of it as a like high-tech solution.
Well, I used a racial equity example in my first comment. I mean, I think it's like substance use. For the first thing you have to do is acknowledge the problem, right? And I think DPH for its better and worse aspects, I think fully acknowledges the problem. You have to admit that there is racism, that there is discrimination against vulnerable groups, that vulnerable groups exist, and that that you need to start by addressing their issues, and that's part of the problem. I think so first you have to admit there's a problem, then you have to care, right? You have to want to help address that problem. And at least with our current leadership at DPH, I think that's very much true. I mean, the department has just issued a mission statement around equity, and it's really, again, it's our primary goal is around health equity. And how you measure it and how you achieve it. And then you have to look at the problem of data with that lens, right? How do you we're trying to modernize data. There's a data modernization initiative that we share with CDC, and the department fully embraces to try to break down silos between all of the hundreds of different data sources, even within the state. And as you modernize and as you develop data systems, you need to do that with an equity lens and make sure, starting with the collection of the data, that you're collecting it in the right places and that you're equitably collecting the data, finding the data, having access to contribute to the data, access to the data that you've collected, work with, engage the communities in that process. All of which sounds good, and I have honestly, I have a mixed sense of optimism about this. To be honest, I'm not sure that we will get there, but I think we're trying, and I think that's what I would say on this.
Thank you. Yeah, it's an age-old problem, and I think a real hurdles, a lot of hurdles.
Thank you so much. So the next question we wanted to ask was about the education and training. So what should the educational program look like to prepare workforce that is ready to tackle EID threats in the coming years? And what is currently lacking in our MPH program or PhD program, DRPH program, and to prepare students or trainees to be ready to tackle these issues? And what is currently lacking to prepare the public health practitioners to be ready to consume results from data science?
I guess I'll go first again. So Larry, do you want to?
You can start.
All right, I'm just going to pick my pet topic to promote here. So I mentioned Massachusetts. The Department of Public Health is leading the Pathogen Genomics Center of Excellence for New England, for this region, and we are also the national lead for the education component of that. And so training the public health workforce in using pathogen genomics is a, first of all, it's a major task, right? It's a newish field. Finding people who are informed and knowledgeable in bioinformatics is not easy, and it's not easy to get them into jobs in the public health department. So we want to be able to train our current public health workforce and our future public health workforce in what are pathogen genomics? What does it mean? How do you determine those data? How do you report the data? How do you look at and analyze the pathogen genomics? Carolyn talked about one aspect of using it to look at drug resistance, but we use it for molecular epidemiology, trying to find linkages between cases. We look at it for global trends. Are we seeing which clade of monkeypox virus are we seeing in the US, and how does that change? Are there changes that impart drug resistance? How do foodborne epidemics fit together? What's the source of that? Where did the highly pathogenic avian influenza from birds get into cows? Did it change genomically? Are there other changes that will preface a change that leads to human infections, or human to human infections even? So how you analyze pathogen genomics? So we're working with Harvard Medical School. We're working with the Broad Institute on this national education. We're trying to develop a primer, a 101 course in pathogen genomics for the public health workforce, and then a whole variety of specialized courses that will help the public health workforce use pathogen genomics. So that's my little plug for what we're working on now, and is still in its infancy, but stay tuned.
Perhaps I'm going to say something that is trivial, but I believe that this is not just a problem and a challenge for public health. So we are at a point in time in which we have to revise every discipline in the way we teach and relate to data science and artificial intelligence and computing. So we are in a world in which, in the next 10 years, probably it will be impossible to do any kind of job without certain fluency. That doesn't mean that you need to be a programmer or a computer scientist, but you really need to have a quantitative approach in many cases that is not taught in many programs. You need to have a fluency of understanding and awareness with respect to the computational tools, including artificial intelligence, and how we bring that into the disciplines is difficult. It's a challenge for everyone. How we train people to those new tools, how we generate the language. I think also there is, if I look really at the topic of this discussion, so data science, models, etc., you've seen that perhaps many of the people in public health that are doing this kind of job are coming from other areas like engineering, physics, computer science, just because, it was a way to, because of their fluency with tools and technical approaches. And I think this from time to time is a shortcoming. And you have to retrain those people to understand public health. So that's, in a sense, is a problem, and it takes years. And so I think we need to invent a new way of generating this workforce of the future, where basically there is more kind of holistic interdisciplinary approach to public health, the technical tools, etc. So that, in a sense, is the new students will be more than, for instance, the faculty themselves. It's more than the sum of the part of engineering, computer science, public health. It's something different at this point. And how to make it happen again is difficult. I'm sure that we need to create more public health technologies program that, could be master programs, could be PhD, could train people. We need more initiatives like the one, on genomics, but there might be many others. And I think it's a daunting task, because it's really revising what we teach and what we do in terms of training.
So I completely agree with that. And I think one of the challenges is that as science and technology progresses, you're adding to things that public health practitioners have to be able to know kind of exponentially, and that's not feasible, right? So you can't be an expert in genomics and satellites and mobile phone data and modeling, and it's just not practical. And so I think we have to think about organizational structures where you have expertise available to you, maybe through academia or some other way, to advise public health practitioners and make sure that they have sufficient quantitative thinking and intuition around public health to know when not to take some of the technologies verbatim, because I think there's often an incentive. We saw during the pandemic where, if you're a modeler and you were working with a public health practitioner, they'd ask you for a model, and one of the answers could be, I'm not giving you a model because that's a stupid question to ask with a model. That's not the right thing, right? And somebody will give you a model. So that's a problem, right? So we have to have literacy. We have to have people who can sit in the middle of that interaction and try to interpret both sides, because the expertise depth is going to get more and more and more, and the technology is going to get more and more sophisticated. So we have to think about the kind of links and the people that we need in that chain. For my feeling, and I could bitch about MPH programs for a long time. My feeling is that we are giving our students traditional methods that are not going to be relevant in the future. We're not giving them sufficient flexibility. We're not giving them a sufficient scope and range. Learning genomics, learning, GIS and modeling and all these things. At the moment, I think we're still fixated on here's how you design a randomized controlled trial to do X. And that's not the way of the future. We've seen that that's not going to be the way of the future. So I think we have to be much more imaginative about our MPHs. And I really also think that we have to teach people more about implementation science. So what I see is at Harvard, we have incredibly bright students, but they don't have the first clue of how you actually run a field study, building trust with people, understanding the need for context-specific knowledge, figuring out how you procure a clip-on microscope in the field when there's no internet. All of that stuff is, it's essential to being able to actually do applied research and understand the setting. So I think that we do our students a disservice by sitting them in classrooms and giving them methods to learn. And we need to get them out there in interdisciplinary teams with engineers, with other people to solve problems. And that's the only way that you learn some of this stuff. They're smart, they'll pick it up, but not the way we're currently teaching them.
Wonderful, thank you. I think maybe we'll just cut to our last question and then hopefully have a little time for questions from the audience. So this is also probably not an easy question to get at briefly, but we're interested, I think, as has been alluded to, AI is here to stay with us. And what role do you see AI playing in this world of surveillance, working with emerging infectious disease threats? I think both positive and negative, right? There are opportunities, but there are also, I think, some definite concerns, especially when we think about equity and other issues. So curious sort of your perspective on that.
So I'm going to give a broad concern and then maybe some hope. So my broad concern is that infectious disease models are wildly uncertain, and people use AI very freely, and it can mean all kinds of things. But the problem is that when your surveillance data sucks, you can't gloss over that with a sophisticated AI model. You just can't. And so I think there's this issue where people are using more and more sophisticated computational techniques and getting further and further away from the importance of ground truthing and validation. And for me, this reflects a more problematic hierarchy in our society where, no offense to Alex, but physicists are very clever and then social scientists are down here somewhere, right? And let alone public health practitioners and nurses or whatever, right? So we have to rethink that hierarchical approach where we assume it's clever because it looks mathematical and fancy, and make sure that we are acknowledging that all these forms of knowledge are valid and important when we're making actual decisions. A very specific thing that I'm worried about is we're using large language models in the context of disaster response in South Asia. So the idea is that there's all these PDF forms, right, that have been filled in reports on disasters with qualitative information about, like, where did these people evacuate to? Where were the vulnerable people? What did they need? And so on. And you can use AI to help practitioners quickly ask questions of vast reams of data that they wouldn't be able to do on their own, and they may not have the technical capacity to do. So like I was alluding to before, trying to bring AI down to the sort of practitioner level to help them manage their own data and think about their own specific context. One issue I have with it is that at the moment, the large language models privilege English language. So at least initially, and I know this will change with translation and things, but at least initially, there's a sort of problem of reinforcing the dominance of English language approaches and so on. So I think with all of these things, we have to think very carefully about what's going in, what the inputs are, and what you're trying to do with it, and who gets to understand that model. But no question, it's going to change a lot of things. And is potentially incredibly powerful.
Yeah, I totally agree. And I think we have to change also the way of thinking of a lot of computer scientists and physicists, if you want. That is, okay, I don't care about the data. I care about the technology and the model I'm developing. And so I don't care if it's good or not. In many cases, I've seen, I would say, really misuse of data just because they were bad data and there was no understanding of the data. So I think we should always start from the understanding of the data, and then the AI can help immensely in that area. Just to give you an example, in our center, we, I would say, invest about a sizable chunk of resources in doing a contact survey, because in the US still, we don't have the equivalent of, okay, now I'm getting technical, of the polymod, of the contact survey that is the gold standard. And then we have all developing models with AI to infer here and there. At a certain point you say, well, but we need to have a ground truth. We need to ask people, okay, who are you, who you are in contact with, how many times a day, etc., in a way that is statistically representative, that is not biased, that can provide information and statistical power for small community, race, gender, ethnicity, etc. So I think we have to start. And the quality of data is central. This is always, when we talk about artificial intelligence, artificial intelligence is as good as the data that you can pipeline into it. And I think the danger are the quality of data, but also, and we could now go on for hours about it, all the biases in the data that you put. So English is one question, but there are many other issues that can be there. So it's great technology. It will change. I totally agree, but we have to be very cautious and how to say, well, all the discussion we're having around AI is even more important in public health because of the impact that AI will have in public health.
Yeah, this is definitely a hot topic, and I'm not sure what to say. I have to say I'm a little bit of a Luddite or a skeptic when it comes to AI, and I took my first course in AI in the 1970s as a high school student, actually, and a course that was entitled AI, and I think there's a lot of hucksterism in AI. I think there's a lot of elaborate tricks that masquerade as AI, and a lot of, and I think everybody wants to call anything they do now AI, and I think that that's a problem. the promise has always been just around the corner. It's just about to be transformative. So having said all of that, maybe we're there actually. Maybe we are at a inflection point where machines are becoming intelligent and in a meaningful way. And so my skepticism now turns more to wanting to be cautious about it, how we use it, making sure that it's, I think for all the reasons that you've talked about, inherent biases, confabulation that AI is capable of, need to be examined and sort of carefully merged to human efforts so that, AI isn't out there doing something without us, maybe badly, and that people are keeping an eye on, and also at the same time so that we can use it in ways that help us.
If I can just add one thing, it's true that there is a lot, as Larry says, now you do a linear regression, and since you want to sell it, you say, this is AI. No, okay, it's a linear regression. Don't this is a okay, it's a little bit more sophisticated, but it's not AI. But it's true also that, probably in the last 5 years, we have seen things in AI that are transformative. And so this is where the potential is, but also the more transformative are, and the more a black box they are generally. And so this is also what has to make us cautious in a way.
Wonderful. Thank you. I think we'll open it up to questions. Does anybody in the room have a question they'd like to ask the panel? Please. Sorry. Yeah, maybe I'll give you the mic so we can run it. Thank you.
Hi, Tom Mahoney from the Harvard Advanced Leadership Initiative. Great presentation. Just a question about wastewater surveillance, which became such an important tool right during the pandemic in terms of identifying, quantifying, characterizing variants through their SARS-CoV-2 through their RNA signature. Is there concern that now that we've moved into, I'll call it, as the administration, I guess, wants us to believe in an endemicity phase of the pandemic, that we're sort of losing momentum around capturing this data with particular emphasis on this pathogen genomics, kind of keeping up with the viral variants as they continue to evolve, whether we watch them or not? And I was just curious as to what your thoughts are around that sufficiency of data on an ongoing basis, and not just limited, of course, to that virus.
The department has been looking at wastewater since way before the pandemic, and it's been used for more than pathogens. I mean, we've been looking at drugs of abuse, for example, in wastewater, therapeutic drugs, antibiotics in wastewater, and of course, antimicrobial resistance, and SARS-CoV-2 was kind of a late application to this, but it has, I think, been revolutionary, and it adds a whole new tool to public health surveillance. It's behavior independent. It doesn't require people to go to the doctor and get a test or do anything else. So it has been really important and I will say extremely useful. And I don't want it, and it can't supplant other aspects of surveillance, but it has certainly been a very useful adjunct to that. And of course, we are applying pathogen genomics to wastewater, and we're looking for pathogen signatures, changes in flu virus, changes in SARS-CoV-2, appearance of new viruses, and so forth. So I think it's been a very useful additional tool, and I hope I hear your note of caution, and I agree.
I'm working with the CDC for their travel genomic surveillance, and I think this is one of probably of the program that will change the way we can monitor and look at infectious disease threat in the future. We all know, when we were scrambling to swab people off planes, etc., that's a nightmare, especially during emergencies. You take the wastewater from aircrafts, or actually it's even more convenient. You can do in what they call the triturators, so the place where all the wastewater of airplanes are put, and basically you can monitor and look at variants of COVID, but you can look at whatever panel of disease you want. And the idea is that even with a handful, 20 sentinels globally, you can outperform any other surveillance system. So I think we need to there is a lot of investment in that. I think obviously the sequencing, the way that we can do that kind of analysis and as there is always the issue to push with those programs and try. There is always now, everything is difficult. Okay, we are off the pandemic. Do we want really to get this system in place? You can imagine, for instance, internationally, what does it mean? You need to have an agreement so that the data collected in Singapore are available also in the United States and in China. And this is where really we need to have to make an effort. I think that it's a low-hanging fruit in terms of technology and data that we can gather, but that there may be hurdles, the small obstacles Larry was mentioning before. But I think they will change the way we do a lot of surveillance.
I would just add, so I did a project where we tried to do environmental surveillance of water in a refugee camp in Cox's Bazar in Bangladesh, and I think so my biggest issue is how we can make these technologies distributed and local and low cost. And I think environmental genomic surveillance does have a ton of promise because you can multiplex your surveillance in a way that is much harder for diagnosis of diseases. The reason that our project really didn't work so well in Cox's Bazar was because of human capacity issues, electricity issues, just basic stuff. We couldn't get the PCRs, the power kept cutting out, all the stuff that happens in low-income countries. So my hope with all of this is that as the technology improves, we remember to always think about how you do it with no electricity and hardly any money and very limited capacity. So for all of these technologies, they have promise to really help the sort of most vulnerable populations. And my concern is that we put a lot of money and investment in research for doing this in the global north without thinking about those other applications.
Do you have any online?
So from our online audience, they asked how to make it so we can share data across different sources like EMR data and Department of Public Health registry data. For example, could there be a mechanism to have a data use agreement to share person-level DPH data with the hospital system, like the VA healthcare system and hospitals across Massachusetts?
I'll just summarize. I think a lot of it was around how can we do better at sharing data across, public health and other agencies. Can we have DUAs in place and whatnot? So it's hilarious. That sounds like a Larry question.
Yes, but it's not a Larry answer. I guess, I'd sum it up by saying so many opportunities and so many barriers, right? And, so in public health, we have sort of dueling mandates. One is to share data, right? I mean, I think we, as I was talking with Laura and Kayoko earlier, that we are actually mandated in Massachusetts to share our public health data with any qualified academic investigator who needs access to it. There's a process. It has a number, 24A, that anyone can apply to access DPH data, and we need to make it available at the least identifiable level necessary, which brings me to the opposite constraint, which is preserving privacy, right? And so we are privy to all kinds of personal information, and we need to make sure that that's safe with us and that we're not sharing data that we shouldn't. Your sexual history, your drug use, there are a lot of personal information that we know about and need to keep private. And so how do you safeguard that information at the same time, make it available? And then the third constraint, of course, is just effort, right? How much can you do, and the overcoming the structural barriers, et cetera, that are needed to access data.
I would just say something about corporate data. So we work with mobile phone operators, and you work with them as well. And one of the things that I think has to be regulated, actually, it has to be mandated that there's data sharing of certain types of what is now should be routine public health data, but it's owned by corporations. And at the moment, they have very little incentive to share it, except under some corporate social responsibility thing. And they do kind of one-off things, and then that's it. So we're working in Central America and the Caribbean with operators to try to get a similar release of data as satellite companies are required to do post-disasters, right? So for a fixed period of time, they have to share data after a disaster. And there are like all kind of like boundaries around it, but we're trying to work on moving regulations forward to get a similar mandate for other kinds of data, which should be seen as public health data at this point, whether that's mobility traces that are appropriately aggregated, whether it's power grid data that's, whatever. So I think that there's this big problem that more and more we'll see private data sets that are siloed, and we need to find a way to make sure that those are seen as public goods. I don't know. It's a complicated regulatory landscape.
Thank you. Any other questions online? Okay. We'll have time for a reception here so we can continue the conversation with refreshments, food, beverage, and whatnot. So really want to thank our panelists for being with us. Round of applause. I personally feel like this has been a really fantastic discussion. I think unveiling a lot of the challenges and I think opportunities that have really been unfolded from the most recent pandemic, but I think for those who've been working in this area for a long time, maybe we're not surprises. But hopefully we have a little bit more momentum to really work on tackling some of these challenging problems. So thank you all again, and look forward to continued conversation.